Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaj. We still have around 11 to 12 days of time, and every day we need to be stronger, revise as many things as possible, revise what the examiner wants, and be confident for the exam. So there's a whole purpose of the spring sessions as a last moment revision. So please go to the learnograph.com and download the Sprint 5 ebook. And there are about 663 topics and 5,000 high-yield facts are made available in the PDF that you can download. And this is the PDF of Sprint 5 that we are discussing now. So there is a link of the learnograph.com below. Please go there and then you can download it. So nice to see Ravinder, Khadija, Burani, Lokesh Babu, and many more who are all online. Lokesh, are you the same Lokesh in the AP or a different Lokesh Babu? So, but anyway, good. Lokesh is also attending today our live class. So every day we will meet. The job of a teacher is to bring that focus, inspire you to do the revision and to tell you, hey, I'm there to hold your hand, to take you a long way to become the winner. So let's make the great beginning, doctor. Yes. So once you go to the learnograph.com, you have on the store the neetpg INICET FMGE Sprint 5, which has 500 MCQs, 5,000 high-yield facts. So there is a list of the 663 high-yield topics on which we give 4 to 5 points and one clinical vignette-based MCQ in this booklet. And I'm quite sure by the time you finish the revision, at least 30 to 40 MCQs in the tomorrow's neetpg are going to get covered in this Sprint 5 book. You need to be very sure about. So I leave the option for you to go and download the PDF from the learnograph.com. So now let us start the discussion. Can the online students can punch? Is the voice loud and clear for all of you, doctor? Can you please punch? Yes. Ravinder and everybody, great. Thank you, Dr. Thank you that the voice is clear, right? Clear and loud. Very good. So, doctor, Lesch-Nyhan syndrome. What is the enzyme you need to remember? HGPRT, hypoxanthine guanine ribosyl phosphoribosyl transferase. That lead to hyperuricemia. So, how will be the clinical vignette in the tomorrow's neetpg exam, doctor, for this question? Child with self-mutilation and gout. It is an X-linked recessive inheritance. Please don't forget, one of the favorite questions. There will be neurological impairment, hyperuricemia. You need to treat with allopurinol. Now, beta thalassemia. What's the problem in this? Mutation in the splicing site. Because of that, there is an abnormal mRNA. And how do they present beta thalassemia? Beta thalassemia presents with microcytic anemia is what you need to basically remember. And target cells. Classically, the presentation of the beta thalassemia. And if you do hemoglobin electrophoresis, it will show an increased HbA2. Please remember, doctor, HbA2. Bone marrow expansion lead to the crew-cut appearance of the skull, and you need to give repeated blood transfusions in thalassemia. These are the crucial points which you need to remember. Then comes the Lynch syndrome. Lynch syndrome is a defective mismatch repair, please remember, and there is a microsatellite instability. That is the genetic event which you need to remember. The microsatellite instability is what you need to remember about. Sorry, there was a little broadcast issue. Yes. All right. I think now it is clear. Good, good. Nice to see almost 16 classmates online. Good, doctor. Now, about the Lynch, how will be the clinical based MCQ? Patient with family history of colorectal cancer presents with rectal bleeding. What genetic syndrome? It is the Lynch syndrome. Lynch is autosomal dominant, increased risk of endometrial cancer. There is a early onset colorectal cancer is what you need to basically remember. So, yeah. So, Atharva and everybody, is the voice loud and clear for all of you, doctor? Yes. So, eye cell disease, one of the favorite questions of the examiner. There is a defect in N-acetyl glucosamine 1-phosphotransferase is the enzyme which is defective in eye cell disease. And that lead to the development of lysosomal debris. So just like Hunter, Hurler, eye cell disease, they have coarse facial features, skeletal abnormalities. It is autosomal recessive. There is a growth retardation, and the death occur in early childhood is what you have to remember. Osteogenesis imperfecta. What type of collagen, doctor? Type 1 collagen defect is osteogenesis imperfecta, not type 2, not type 3 or 4. Type 1, because bone has worn type 1 type of collagen. Bone में होता है type 1 collagen. So type 1 collagen defect leading to brittle bones. A child with multiple fracture, blue sclerae, that's how the presentation of osteogenesis imperfecta. And it is autosomal dominant inheritance. There's a hearing loss, there's a dentinogenesis imperfecta, collagen, COL1A1, COL1A2 mutations are the two mutations that you need to remember for the tomorrow's neetpg. Then Menkes disease. There's a defective ATP7A. That is the gene. Impaired copper absorption. So, how will examiner ask a question? Sparse, kinky hair with developmental delay. What is your diagnosis, doctor? It is the Menkes. Menkes is also X-linked recessive inheritance, hypotonia, seizures, low serum copper and ceruloplasmin is what you have to remember. Then comes Marfan syndrome. FBN1 mutation. FBN1 mutation is what you need to remember. Defective fibrillin. Defective fibrillin. A tall patient, long limbs with aortic dissection. That's a typical clinical vignette. It is autosomal dominant. There's a lens dislocation, mitral valve prolapse, pectus excavatum. They're all the features of the Marfan. Prader-Willi and Angelman syndrome. 1 to 2 comments. See, always what is the sprint? The sprint is most frequently tested questions, 4 to 5 points you should know, and be ready for a rapid revision of the exam. That's the whole purpose of the sprint. So for this PDF, please go to learnograph.com. There you have the sprint 5 PDF ebook available. By paying $200, you can download. You have all these 500 MCQs and 5,000 high yield facts available. I am actually discussing through the book only. So take every opportunity, but sit with a friend, ask him to quiz you, and that is how you need to do the revision last moment. So paternal deletion lead to Prader-Willi. Prader-Willi is Papa. Angelman is maternal deletion. Amma is Angelman. It is a mutation of the chromosome 15. Both the Angelman, Prader-Willi is both of them are chromosome 15. But if the paternally given chromosome 15 में mutation है तो मिलेगा Prader-Willi. Maternally given chromosome 15 में, if there is a deletion, mutation, that lead to the Angelman. So how does Prader-Willi? This is called genomic imprinting. This phenomenon is called genomic imprinting. That is, if something comes from mummy, there is a different thing. If it comes from daddy, there is a different thing. Genomic imprinting. Hyperphagia, obesity, intellectual disability is the presentation of Prader-Willi. Typically, there will be hypotonia in infancy. They will have hypogonadism, short stature, and a uniparental disomy in about 25% of cases. Whereas in Angelman, what do you have, doctor? Maternal deletion, where there is a mutation of UBE3A on chromosome 15. There is a intellectual disability, seizures, but always a happy, smiling, happy demeanor they will be having. That is Angelman. So they present with ataxia, frequent laughter, severe speech impairment, and happy puppet syndrome is the name which is being given to the Angelman, is what you should remember. Coming to cystic fibrosis. Cystic fibrosis is F508 CFTR gene mutation. Because of that, there is a impaired chloride channel. They will have recurrent lung infection, salty sweat. The mother is tasting the baby salty, failure to thrive, classical description. It is autoaggressive. There's a pancreatic insufficiency. It can present with meconium ileus in newborn, the thick meconium secretions, and you need to give chest physiotherapy. Duchenne's muscular dystrophy is dystrophin gene leading to myonecrosis. So whenever there is any progressive muscle weakness, calf hypertrophy, you should think it is X-linked recessive. Please don't forget the favorite question of the examiner, right, doctor? So Gover's sign, whenever the baby need to get up, Duchenne's muscular dystrophy, he will be holding his, typically the thighs, then as such he is climbing on his own body, he will get up because the proximal muscle weakness. Gover's sign. They have a significant elevated CPK levels, classical, and a very early age of onset before age 5. Myotonic dystrophy. What is the problem in this? It is the CTG, repeat, where in DMPK gene leading to development of myotonia. What do you mean by myotonia? If you happen to hold and give him a shake hand, he won't leave the grip that easily. It takes a long time before you get back your hand. That is called myotonia. CTG, repeat, DMPK gene, myotonia, you should remember. They will have muscle stiffness, cataracts. That's how they clinically present. So today, if you look at the neetpg exam, doctor, 95% questions are all clinical minute based questions. At least 40 to 50 image based questions are there. So you should be well prepared. You should be able to smell the diagnosis from distance. Myotonic dystrophy is autosomal dominant. There's a frontal balding. Don't try to look at all your baldhead friends with doubt. There'll be gonadal atrophy, hatchet face appearance, classical of myotonic dystrophy. Then what do you see in Fragile X syndrome? CGG, repeat. मेरे साथ और एक बार बोलो. CGG, repeat. To become a cardiologist, neurologist, nephrologist, cardiothoracic surgeon, neurosurgeon, you don't. Unfortunately, you need to mug this. Where is CGG? Where is CTG? अगर नहीं review करे तो, reproduce नहीं कर पाए तो, competition is cutthroat, doctor. You need to be more shrewd than the competition. CGG, repeat. FMR1 gene, there is a decreased expression of the gene in Fragile X. So how will a child present with Fragile X? Intellectual disability, large ears, long face. That's how you diagnose. It is X-linked dominant. X-linked dominant. Very few conditions are X-linked dominant. You get a lot of X-linked recessive, but X-linked dominant is Fragile X. One more condition, vitamin D resistant rickets. That is also X-linked dominant is what you need to remember. So there is a macroorchidism, big testis, mitral valve collapse, hand flapping behavior in Fragile X. So what do you see in vitamin A deficiency? Bitoid spots which are due to squamous metaplasia. What do you mean by metaplasia, doctor? One type of cell changing into another type is called metaplasia. So you get xerophthalmia, immunodeficiency in vitamin A deficiency. Then growth retardation, you need to treat with vitamin A supplements. Wernicke encephalopathy is thiamine deficiency. Thiamine deficiency. And whenever alcohol comes to you with hypoglycemia, if you only give glucose, you will end up in precipitating Wernicke. That's the reason always add thiamine, vitamin B1 while giving glucose in an alcoholic. So any alcoholic with triad of clinical features. What is the triad, doctor? Confusion. Very good. Just now one of the students paid 200 rupees to download the PDF. Very good, doctor. So every day I do a sprint and give you a set of facts that you need to revise. ये जो sprint 5 वाला PDF से कम 30 to 40 questions in neetpg guaranteed. मेरा बात मान लो. ये concepts आ गया तो आपको. Confusion, ataxia, ophthalmoplegia is the triad in Wernicke's encephalopathy after receiving glucose. So which part of the brain? Mammillary body atrophy. And you can prevent by giving thiamine before glucose. Confusion, ophthalmoplegia, ataxia is the triad of Wernicke. So typically pellagra. Niacin, vitamin B3 comes from tryptophan. Any tryptophan diverted, like in Hartnupp's disease or carcinoid syndrome. Lot of tryptophan is converted into serotonin in carcinoid. That's the reason you get the 5-hydroxytryptamine, it gets converted into. You get pellagra. So dermatitis, dementia, diarrhea. Fourth D is death. So carcinoid में हो सकता है. Corn, जो भी corn based diet खाते हैं ना, उसमें pellagra हो सकता है. Treat with niacin. Kwashiorkor is PM. All of you know very well. Kwashiorkor is PM, where there is a liver fatty change. 1 minute, doctor, I got a call from a patient 1 minute, 1 minute. Be online. So, sorry for a short interruption, doctor. So, one of my patients, she has rheumatoid arthritis with uncontrolled diabetes, was started by somebody metformin about 1 week ago, along with sitagliptin, and she has profuse loose motion. She's a top chartered accountant. So, what I have to do is to give rifampicin 400 milligram twice daily, along with there's a tablet called IB-Set, which will decrease the irritability of the bowel. A lot of times, sitagliptins are very good, sitagliptin, vildagliptin, but gliptins are associated with nausea, vomiting, diarrhea. Similarly, metformin also in few people will lead to diarrhea. So always you need to weigh the side effects versus tolerability whenever you are administering the diabetic drugs. So the patient is very much worried. So yeah. So let's get back to the game. Kwashiorkor is a protein malnutrition, liver fatty change, flaky paint type of dermatosis, and protein refeeding, just not energy. Protein refeeding need to be done. Coming to alcoholism. Alcoholism may, why the person going to lactic acidosis? Whenever you take the alcohol typically will cause an increased NADH by NAD ratio. And an increased NADH typically will lead to the development of lactic acidosis. So, the alcoholism leading to the development of the lactic acidosis is the most important thing that you need to remember. So, any patient presenting with hypoglycemia, so please remember, any patient presenting with hypoglycemia, lactic acidosis, hepatic steatosis, what is the main reason for all that? Alcohol lead to increased NADH by NAD ratio is what you should remember. So what is the effect of alcohol? Alcohol typically lead to inhibition of gluconeogenesis. It promotes the fatty acid synthesis. It leads to hypoglycemia. Lactic acidosis is what you need to remember. Now comes aspirin-induced hyperthermia. Whenever you give aspirin, generally aspirin is an anti-inflammatory. That's the reason we think that aspirin toxicity, excess way. What will happen? We think that maybe they're going to hypo. No. Aspirin salicylates. What is aspirin? Acetyl salicylate. So whenever you give salicylic acid, it is anti-inflammatory, but excess amount of salicylates lead to development of hyperthermia. Why? Salicylates increase the mitochondrial membrane permeability. Salicylate lead to hyperventilation, leading to respiratory alkalosis. So, hyperthermia, respiratory alkalosis after taking aspirin. Why? Because they increase the mitochondrial membrane permeability. They uncouple the oxidative phosphorylation. Respiratory alkalosis initially. Very nice to see. 20 online classmates. So please join the sprint sessions. I conduct these sessions almost across the year, doctor. So please like this video, write your comments after the broadcast is over in the comments, not in the chat box, but you can write comments. You can regularly comment, and that will help it to become viral, because YouTube has an algorithm which will make any video become viral by the number of likes that it is getting. And also, please share this link in all your social media groups. You are my best brand ambassadors. So salicylates typically uncouple the oxidative phosphorylation. Initially, they lead to hyperventilation and respiratory alkalosis, then metabolic acidosis. You need to give a supportive care, and cooling is what you need to remember. Now comes hereditary fructose intolerance. Aldolase B deficiency, fructose 1-phosphate get accumulated in hereditary fructose intolerance. It is autosomal recessive. Avoid fructose and also sucrose. Not only fructose, but also sucrose. There's a failure to thrive, hypoglycemia, jaundice. It is very much fatal. The hereditary fructose intolerance, which is aldolase B deficiency. Then comes classic galactosemia, right? So there is another entity which is not as bad as hereditary fructose intolerance. It is called essential fructosuria. Essential fructosuria. So that is due to fructose 6-phosphatase deficiency. So that is the fructokinase deficiency. Fructokinase deficiency. That is different from hereditary fructose intolerance, which is aldolase B deficiency. Often examiner will ask whether you know the difference between these two or not. Please try to not make any mistake. Classic galactosemia is GALT deficiency. GALT deficiency, right? And there is an accumulation of galactitol, and that accumulates in the eye, osmotically active. It leads to cataract. So classic galactosemia is GALT deficiency, and it is autosomal recessive. Avoid not only galactose but also lactose. Similarly, in the hereditary fructose intolerance, not only fructose but also sucrose. Please don't forget. And intellectual disability occur with classic galactosemia. You find galactose, just like glucose, is also a reducing sugar in the urine, is what you have to basically remember. Now, what are the complications of the diabetes? Why diabetes lead to so much injury? In diabetes, hyperglycemia and all that excess glucose becomes sorbitol, and that lead to osmotic damage. So diabetic patient developing cataracts and neuropathy is because of sorbitol accumulation. And diabetes affects the lens, retina, Schwann cells. Lens leading to cataracts, then retinopathy, nephropathy, neuropathy, ultimately going to Tirupati in diabetes. And typically, why lens, retina, Schwann cells are selectively affected by the hyperglycemic injury? Because excess glucose will cause the sorbitol formation, and to metabolize the sorbitol, they don't have sorbitol dehydrogenase. That's the reason. And it leads to osmotic damage. All that excess sorbitol inside the cell will pull in a lot of water, is what you should remember. Now, recurrent Neisseria bacteremia. Where do you get? You have C5 to C9, terminal components of the complement pathway. Terminal complement deficiency, you get Neisseria bacteremia. Because terminal complement C5 to C9 typically will form MAC. MAC is membrane attack complex. which lead to all perforations in the cell wall of the bacteria. So that's the reason recurrent bacterial infection, susceptibility to Neisseria, and how do you discover this terminal complement deficiency? CH50 assay you need to basically do. Wow, very nice to see 23 online classmates. Very good, doctor. Always these sprint sessions are very interesting because they will make you to revise in a very short period of time the most tested high yield material. That is the secret of the adrenaline rush we get by these sprint sessions. So please tell all your friends, share this YouTube link, please like this video, subscribe to the channel, and that will make the video get more viral spread, which will help a lot more students. Hereditary angioedema, C1 esterase inhibitor deficiency is hereditary angioedema. So how will a clinical case question will come? Recurrent episodes of swelling without urticaria. What is the diagnosis? Hereditary angioedema. It is the unregulated kallikrein activity. Normally, bradykinin is being broken down, but it become elevated. It is an autosomal dominant inheritance, and you treat with C1 inhibitor concentrate because hereditary angioedema is due to C1 inhibitor deficiency. Then comes PNH, paroxysmal nocturnal hemoglobinuria. It is the PYGA gene mutation. So normally RBC, when they are floating in the blood, they are vulnerable to be broken down by the complement system. And that is being prevented by a factor called decay accelerating factor. So whenever there is lack of CD55, CD59, then the decay accelerating factor will be missing, and the RBCs, when they are released into blood, are vulnerable to the destruction by the complement system. Why only in the night? Why it is nocturnal hemoglobinuria? Why hemolysis occurs in the night? Because for this complement mediated lysis of RBC hone ke liye, you require a alkaline pH. So whenever we go to sleep, it requires acidic pH, not alkaline, acidic pH. Whenever we go to sleep, our respiratory rate comes down. That leads to respiratory acidosis. pH of the blood decreases, and that make the RBCs vulnerable to the complement-mediated hemolysis is what you need to remember. So how is a clinical presentation and a clinical minute-based question on this, doctor, in the tomorrow's neetpg? Hemoglobinuria. Patient has pancytopenia, and the flow cytometry show lack of CD55, CD59. That's how you diagnose PNH. In PNH, there is a increased intravascular hemolysis, risk for thrombus formation. And how do you treat it, doctor? We give eculizumab. Eculizumab is what you need to basically remember. So very nice to see Kumar, Jitendra, and many more. So please make sure, doctor, to like the video and to share the video to all your friends in all social media and make this video become viral. Now, type 1 hypersensitivity. It is IgE mediated. There's a degranulation from the mast cells and the release of the histamine. And the late phase of the type 1 hypersensitivity involves chemokines, eosinophils. So a patient has high angioedema, bronchospasm after exposure to allergen. It's an example of a type 1 hypersensitivity. We do the skin prick test in order to diagnose the type 1 hypersensitivity. So what is type 2 hypersensitivity? Either antigen is fixed on the tissue, but the antibody is flowing freely in the blood. Whereas type 3 ka matlab, antigen is free, antibody is free, together met, formed an immune complex, and that shit has gone and fell on tissue. So immune complex deposition is type 3 hypersensitivity, whereas antibody against a fixed antigen, like a glomerular basement membrane antigen, is type 2 hypersensitivity. So patient with hemolytic anemia from a mismatched blood transfusion, what type of hypersensitivity is a favorite MCQ of the examiner? So it is type 2, it involves complement activation, it can lead to good posture syndrome, RH incompatibility. Typically in type 2 hypersensitivity, may direct Coombs test is typically positive, is what you should remember. Then what is type 3 hypersensitivity? As I told you, antigen antibody complexes, they activate the complement. So that is type 3. So fever, rash, joint pain after taking a medication, it's called Arthur's reaction. Serum sickness, they're all type 3. Lupus nephritis, type 3. In type 3, there is a neutrophil recruitment, whereas in type 1, there is a eosinophil recruitment. And type 3, Arthur's reaction is associated with vasculitis, is what you need to basically remember. So Dr. Sachin Kalyan is saying, sir, is it high yield in last days as I have not prepared this year well? No problem. Something or other, you keep yourself busy to give an attempt to study without looking at results. Sometimes miracles happen. It all depends upon how you studied during your MBBS. So many factors are responsible. Sometimes certain clinical questions, you can be able to make a good guess, right? So that's the reason, without thinking about the result, just prepare the next 10 days and go to exam. And please remember, doctor, go to learnograph.com. I'm leaving the link below. So there are totally 600 plus items like this, 5,000 high yield facts, almost 500 MCQs are there in the PDF of Sprint 5, which I made available on the learnograph.com ebook PDF. Download it. You may be having a lot of study material, but what is important in the last moment, what to revise, what to focus, what is high yield, what examiner is going to ask, that thing you need to master in a very focused way. And I will give you these sprint sessions and the PDFs, I publish them. It just costs you around $200 to buy a PDF and download on the learnograph.com. Please tell all your friends, right? Yeah. So Dr. Prema is saying, good evening, sir. I'm a FMG student. Can I watch this sprint? Very much. Whether it is FMG, INACET or USMLE or neetpg. Aajkal everything is one and same. There is nothing different. Concepts are same, topics are same. The way you need to prepare is same. There is not much of difference at all. So that is the reason. Please welcome Dr. Prema and also bring all your friends in the world, across the world, China, Russia, everywhere, Ukraine. Tell them that Dr. Murali Bharadwaj is available free for you on the YouTube. So there are 50 full-scale mock test PDFs available as ebooks on the learnograph.com. Today only go and download them. And who is the good teacher? A good teacher is not the one who rubs knowledge on you. A good teacher is the one who will inspire you to do the revision, who will give you very focused material. Kam pado, acha rank banao, topper bano. That is the dream, holy dream of every student going for the neetpg doctor. ज्यादा पढ़ो, 10 घंटे पढ़ो, 12 घंटे पढ़ो रोज को, वो सब बकवास है. You will get the testicular spermatogenesis will stop happening for this kind of heat and temperature if you sit 10 hours, 12 hours in reading. Kindly don't do that, right? You may become topper, but not useful for anything else. So that's reason. Enjoy preparation. Have 2 to 3 friends. I'm already your classmate, roommate, study mate, benchmate to inspire you to do the revision, doctor. Right? So that is a deal. Every day, come share this YouTube channel to all your friends in all the WhatsApp groups. We will all study together. I'm always there to help you. So it's not about the apps, it's not about the video lectures or anything. It's all about you internalizing the concepts, knowing what examiner is going to ask, simple things that examiner is going to ask. That is the secret of winning the entrance exam. Any great guru will teach the same. So in the past 25 years, I had privilege to mentor 300,000 medical students and doctors, many people through this YouTube channel also, completely free. Many of them are toppers. Now they are top neurosurgeons, consultants, cardiothoracic surgeons, cardiologists. Once upon a time, they were all sitting like you, thinking, oh my God, will I get seat or not? You will get the seat provided you believe that you are born to become the winner. So that is very important, doctor. So continuing our journey, type 4 hypersensitivity. Type 4 hypersensitivity is T-cell mediated. It is CD8 plus, directly kills the target cells. So how is the presentation? Patient developed a rash 48 hours after contact with a poison IV. What type of hypersensitivity? Type 4. It's a delayed type hypersensitivity. Granuloma formation TB is a type 4 hypersensitivity. Contact dermatitis is type 4 hypersensitivity. MAN2 test for TB is type 4 hypersensitivity is what you should remember. So acute hemolytic transfusion reaction is type 2 hypersensitivity. So patient present with fever, chills and back pain because of the blood transfusion. What type of hypersensitivity examiner asks? Your answer is, it is typically type 2 hypersensitivity. Type 2 is complement mediated. ABV incompatibility is type 2. Immediate onset of symptoms. And you stop transfusion immediately. The next hot topic, surely one MCQ is going to come, is primary immunodeficiency disorders. 3-4 पॉइंट आप याद रखने की कोशिश करो जो शूर शॉट पूछेगा कल के नीट पीजी में. So many times in the exam hall, मेरा आवाज आपको सुनाई देगा, आपके कानों में रिंग होगा. अभी हम जो डिस्कस कर रहे हैं वो सब आपको रिंग देगा कानों में. X-linked agammaglobulinemia of Bruton. It is a defect in BTK gene. In this, there is no maturation of B cells. So, how does it? That's the reason B cells nahi hai, to antibody count तैयार करेगा. No B cells, no plasma cells, no plasma cells, no immunoglobulins. That is what you need to remember. So a young boy with recurrent bacterial infection and low levels of all immunoglobulins, IgG, IgA, IgM, all of them. Which defect it is? It is the BTK gene because it is X-linked agammaglobulinemia. It presents after 6 months of age. In this, there are no tonsils, no lymph nodes, low serum IgG, IgA, IgM, and treat with IV immunoglobulin is the treatment. Then comes discharge. Discharge hota hai 22q11 microdeletion. In this, there is a failure to develop 3rd, 4th branchial pouches. Favorite question. 22q11. So how will be the clinical minute-based question? Cardiac anomalies, hypocalcemia, recurrent infections, 22q11 deletion. ये सब बोलने के बाद भी अगर discharge आपके मन में नहीं आए तो, right? Then examiner will think, अरे वाह क्या मछली मिल गया मुझे. Huh? So thymic aplasia leads to T-cell deficiency in discharge. In discharge, there is a hypoparathyroidism because it is 3rd and 4th branchial arches now. They are also responsible for the parathyroid glands. hypoparathyroidism. It causes hypocalcemia. Conotruncal cardiac anomalies can occur, like truncus arteriosus. Catch-22 is the mnemonic. Catch, that is the 22Q11 is what you need to remember. Then comes hyper IgM syndrome. This is another immunodeficiency disorder. Defective CD40L. There is a surface protein called CD40L on helper T cells, Th cells. So this is called class switching defect. Immunoglobulins initially start as one major molecule that become changed. So class switching defect. IgM initially forms. From IgM, IgG, IgA, IgE are supposed to form. But the class switching of the immunoglobulin doesn't happen. That it lead to hyper IgM. And why does it not happen? Because of the CD40L on Th cells is deficient. Right, doctor? So, recurrent bacterial infections, high levels of IgM but low levels of IgG, IgA, IgE is the presentation. Hyper IgM syndrome is inheritance, increased susceptibility to pneumocystis carinii pneumonia. But the IgM levels kaisa rehta? Normal or elevated are IgM. But IgG, IgA, IgE, these three are low in hyper IgM syndrome. Now comes leukocyte adhesion deficiency type 1. It is also called LFA1 integrin defect is leukocyte adhesion deficiency. In this, there is an impaired migration of the WBCs. Problem is impaired, whenever there is any inflammation to that area, all the WBCs need to migrate, impaired migration. So how will be the clinical presentation, doctor? Please don't forget. A child presents with delayed separation of the umbilical cord. Recurrent bacterial infections. Immediately you should jump and answer leukocyte adhesion deficiency. So what's the problem in this, doctor? In this, impaired chemotaxis, high neutrophils in the blood, absence of pus formation. Pus kab banega only when WBCs go to the site of inflammation. So absence of pus, recurrent skin and mucosal infections, classical presentation. Then is Chidiac-Higashi, LYST mutation, list mutation. There is a problem in the microtubule dysfunction. How will be the clinical vignette? Child with albinism, neuropathy, recurrent pyogenic infections. Immediately you should jump and answer Chidiac-Higashi. मैं ये PDF के शुरुआत में 650 high-yield topics का list दिया. So today only go pay $200 and download the PDF, and then you know. At least if you know the, अगर नाम पता चले तो काफी है एग्जाम में जीतने के लिए, ठीक है? Now, Chidiac-Higashi is autosomal recessive. Giant granules are found in the neutrophils. Today only go to the Google and search in the images how the giant granules of Chidiac-Higashi look like. It can come like an image-based question. Also, let me tell you, there are 50 full-scale grand tests. Each grand test may around 30 to 40 image-based questions. Baki cheeze, they're all the classical clinical vignette based questions. This 50 full-scale grand test का revision करो, रोज sprint session में participate करो, seat नहीं मिले तो मेरा जिम्मेदार, ठीक है? Now, albinism, neuropathy, recurrent pyogenic infections. Think about Chidiac-Higashi. And Chidiac-Higashi can go into pancytopenia. You need to treat with bone marrow transplant is what you need to remember. Then comes chronic granulomatous disease. In this NADPH oxidase defect is there. In this, there is a decreased ROS system, which do the free radical injury, free radical detoxification karne wala system is decreased. Right? Now, typically in chronic granulomatous disease, catalase positive organisms, nitro blue tetrazoleum test is negative in them. Recurrent infections are there. If you see these three buzzwords, jump and answer CGD. Chronic granulomatous disease, X-linked recessive, recurrent skin and lung infections, granuloma formation, dihydrorhodamine test. Dihydrorhodamine test. Very good. Just now another student bought 200 rupees pay करके a sprint 5 का PDF को download कर लिया from learnograph.com, and I'm very sure that these are the spicy things. इतना लंबा लंबा नोट्स देना, आपको ज्ञानी बनाना, वो नहीं है. हर एक टीचर का फर्ज क्या है? What is the responsibility of a teacher? To give you very concentrated study material, make you to master that study material, sit along with you, discuss it. That is the role of a good teacher. And all good teachers are bad students. Remember, I was a bad student. I know the struggle of a student, and that makes me to understand कितना tension रहता है. It is like a T20 World Cup में the so-called very good players also will fumble and go into dugout. That is the situation of us in the neetpg exam, doctor. So, good. Now, candida infection in immunodeficiency. Whenever any decreased granulocytes, decreased T cells, that lead to candida infection. So, a immunodeficiency patient presents with oral thrush and systemic candidiasis. Which type of cell is deficient in them, doctor? Granulocytes. So, granulocytopenia, a granulocytosis lead to recurrent infections. Treat with antifungal medications, high mortality if you don't treat well, and you need to prevent with prophylactic antifungals. Then comes GVHD, graft versus host disease. Donor T cells attack the host cells. Fundamentally क्या होता है? एक रेसिपिएंट रहता है, एक डोनर रहता है. आप डोनेट किया, प्यार से डोनेट किया, मोहब्बत से डोनेट किया, मगर आपके डोनेटेड टिश्यू में still if immunocompetent T cells are there, they will go and attack the host tissues. That's called graft versus host disease. So, how will be the clinical presentation? Clinical Binet-based MCQ. Patient recently underwent a bone marrow transplant, presents with a maculopapular rash, jaundice, and diarrhea. So, what is this? This is typically a classical story of graft versus host disease. Bhaiya, graft versus host disease is cell-mediated injury. Hence, it is a type 4 hypersensitivity. It involves HLA mismatch, commonly seen after stem cell transplant, and you treat it with immunosuppressants. Then, in CGD, क्या होता है? Chronic granulomatous disease में catalase positive infections recurrently infect. So, what are the common organisms? Serratia marescens, Staphylococcus aureus are the common catalase positive organisms. Infections increase in chronic granulomatous disease. Dihydrorhodamine test, granuloma formation. Treat with prophylactic antibiotics is the rule which you need to remember. Then comes hemolytic uremic syndrome. So, there is a toxin called Shiga toxin which will go and damage the endothelium. How will the presentation? A child had hemolytic anemia, thrombocytopenia, acute renal failure, rise of the creatinine, urea after a recent diarrhea. Think about hemolytic uremic syndrome. E. coli O157 strain. It releases Shiga-like toxin which damages the endothelium. You need to give supportive treatment I still remember a child who I need to do hemodialysis to manage the renal failure because of the HUS. Avoid antibiotics, very important. If you give antibiotics, there is a greater amount of injury you are causing in hemolytic uremic syndrome. One of the favorite questions of the examiner. So examiner क्या करेगा? Silently seduce करेगा. क्यों? हेमोलाइटिक एनीमिया है, थ्रोम्बोसाइटोपेनिया है, एक्यूट रेनल फेल्यूर है, डायरिया भी है. Do you like to give antibiotic? That is the elimination answer. Such a characteristic question. If you do that wrong, gone in the competition. Now, doctor, tetanus. Tetanospasmin. Why tetanus occur? Tetanospasmin blocks the inhibitory neurotransmitters. It blocks the GABA. It blocks the release of the glycine. So patient has a muscle stiffness, lockjaw, puncture wound equal to tetanus. You need to give antitoxin. It leads to muscle spasms, rigidity is what you should remember. Then comes the botulism. The toxin of the botulism cleaves the snare protein. Where is snare protein, doctor? Acetylcholine, the neuromuscular junction, is present in vesicles. The vesicles need to degranulate and release acetylcholine. Oh, vesicles के membrane के ऊपर होता है snare. So how does botulism present? Clinical minute. Flaccid paralysis, difficulty swallowing after consuming canned food is typical of botulism. Infant botulism happen from honey, treat with antitoxin and give supportive care. Gas gangrene, typically gas gangrene is caused by Clostridium perfringens. Perfringens release alpha toxin. It has a phospholipase activity. It is a lecithinase. It leads to myonecrosis. It rapid tissue destruction. So treat with debridement and give antibiotics. Toxic shock syndrome toxin. It's called TSST1. It acts like a super antigen. वो पूरा दुनिया को बोलेगा मैं आ गया बोल के super antigen that will cause an intense inflammatory release, viral response. So you have to help to make this video viral. Kindly like this video and also share this YouTube link about our sprint sessions to all your friends in the social media groups, college classmates, everywhere, Telegram groups, so that gives opportunity for many more people to know. To become a topper, it is not very difficult. It is a little focused, combined study with Dr. Murli Bharadwaj sir. So the whole morning, I practice clinical medicine, but evening, I become a Dracula to sit with you, to bring out all that blood needed to become the topper. So remember, don't worry, I'm there with you. You're going to be the topper. अपना हिम्मत हारना नहीं. लास्ट मोमेंट में इतना रिवीजन करना बोले तो हम थोड़ा हाइबत हो जाते. होने का जरूरत नहीं है. If we get depressed, we forget. Depression is called pseudo dementia. So there is a fever, rash, hypotension, multi-organ failure is toxic shock syndrome. It is a Staphylococcus aureus toxin. It is a super antigen which virally lead to the T cell activation is what you need to remember. 29 online classmates. I'm so happy to see. Once upon a time, I used to have 500, 600 students attending on the YouTube live. Slowly, as I became busy in clinical practice, I was not getting time. But from now onwards, I'm going to be with you every day and inspire you to become the topper doctor. So now, High levels of interleukin 1, interleukin 2, interferon gamma, TNF alpha, they all lead to toxic shock syndrome, is what you need to remember. Now, doctor, there's a little repetition. I'll just skip the repetition. Yeah. So this part is slightly repeated. I don't know. Yes. There are about 10, 20 points that got repeated. Sorry for that. So now, disseminated intravascular coagulation and shock occur whenever there is any gram-negative sepsis. Why? Because gram-negative bacteria release the lipopolysaccharide, and that lead to activation of macrophages, which lead to the shock. So septic shock, gram-negative bacterial infection, which component primarily responsible? It is the lipid A of lipoprotein, lipopolysaccharide triggers the macrophage activation. It involves TL receptor 4 and CD14 complement activation. It leads to tissue factor activation, commonly seen in severe infections. All the prosthetic device infections are by staph epidermidis because it forms the biofilm. So prosthetic valve develops infection means it is that biofilm that follows adherence, allows adherence to the devices. It's common in catheter-induced infections. Prosthetic infections is what you need to basically remember. Right, doctor? 1 minute. So, doctor, which organism is responsible for the prosthetic device infections is the question of the examiner. It is the Staphylococcus epidermidis is what you need to remember. And basically all this film, everything involves extracellular polysaccharides. And the only way is not by giving more and more antibiotics, but you need to remove the device, then only you can be able to take care of these biofilm forming organism infections. Endocarditis secondary to S. sanguis, it is because of the dextrons biofilm production. Dextrons bind to the fibrin platelet aggregates. Typically, this is seen on the damaged heart valves, commonly after the dental work, and it leads to subacute endocarditis. Streptococcus sanguis is what you need to remember. Pseudomembranous colitis is secondary to Clostridium difficile. There's a toxin A, toxin B, both of them damage the enterocytes. In this, there is a watery diarrhea. It follows antibiotic treatment. And how do you diagnose, doctor? You do stool toxin assay. And how do you treat pseudomembranous colitis? Metronidazole, vancomycin. Metronidazole, vancomycin. You should not forget. Diphtheria. It is an exotoxin of the diphtheria, which inhibits the protein synthesis by ADP ribosylation. Protein synthesis may ADP ribosylation of the elongation factor 2. Elongation factor 2 is required for protein synthesis. But if the exotoxin goes and causes ADP ribosylation of the EF2, then that inhibits the protein synthesis, is the mechanism of diphtheria. Pharyngitis, pseudomembranes, myocarditis, that is all about diphtheria. Exotoxin inhibits protein synthesis, it leads to pseudomembranous pharyngitis, myocarditis, neuropathy is what you should remember. So how do you get virulence in tuberculosis? There's a cord factor. What is that factor called? Cord factor, which activates the macrophages. So chronic cough, weight loss, cascading granulomas. You should think of TB, and TB is caused by cord factor that promotes the granuloma formation. It induces the TNF alpha release, and the sulfatides, which are formed by the mycobacterium, they inhibit the phagolysosomal fusion. So our phagocytes will not be able to kill the mycobacterium because sulfatides in the cord factor inhibit the phagolysosomal fusion, is what you need to remember. Tuberculoid leprosy, it is a Th1 immune response. In helper T cells, you have Th1 immune response. The symptoms of tuberculoid leprosy are relatively mild. So skin lesions, numbness, positive lepromin skin test. What type of leprosy? Tuberculoid. Whereas in lepromatous leprosy, there is a immunodeficiency. That's the reason the lepromin test will be negative. And mild symptoms in tuberculoid leprosy is because the Th1 response. Treat with dapsone and rifampicin. Why there is no effective vaccine for gonorrhea? Because gonorrhea is a sexually transmitted disease. If you have a vaccine, it will be world renowned, but there is no. Why? Because gonorrhea has the pilus proteins that have a antigenic variation, is what you need to remember. So urethritis, sexually transmitted, resistant to reinfection. So what organism it is? It is typically gonorrhea. And there is no effective vaccine. Cystitis, pyelonephritis by E. coli. They're all because of the fimbriae, P. pili. So UTI has E. coli in urine culture. What virulence factor means? It is the fimbriae, is what you need to remember. Fimbriae helps to attach to the bladder. E. coli are the most common cause for UTI. Pneumonia, neonatal meningitis. They are caused by E. coli. It has got a K capsule which inhibits the phagocytosis. And neonate with fever, with irritability, E. coli is isolated means K capsule is what you should remember. Chlamydia, why they are resistant to the beta-lactam antibiotics? Because beta-lactams inhibit the classic peptidoglycan. And they don't have a peptidoglycan in their cell wall. That is the reason. So no peptidoglycan because of the muramic acid reduction. And how to detect the chlamydia, doctor? NAAT, N-A-A-T, nucleic acid amplification test. And what is the drug of choice on the chlamydia? Azithromycin, doxycycline. That's the reason whenever somebody has got a fever, if that fever is not coming down, what will you do? Give him a shot of doxycycline 100 milligram twice daily. For a few days, he will become better. That's what you need to basically remember. Thank you so much, Dr. Sumant, for the compliment. I'll be really happy if you all guys can like the video, share the video, and write your comments below the video after the broadcast is over. That will help the YouTube to make it viral, right? Also on your Instagram pages and also your classmate Instagram pages, please post this video and make it viral. You are my best brand ambassador. As many number of people, we try to make this become aware, right? So, yes, doctor. And also go to learnograph.com. Don't forget, in learnograph.com, the link I left below, just by paying $200, you can download this PDF and you have almost 600 items At least 30-40 questions straight away come from the Sprint 5 PDF. I'm betting on it. Every day I release one Sprint PDF on the learnograph.com. Just download, consume it, and then do the last minute revision, right? So at this moment, it is not how extensively you read, but how limited you read, how much you can revise to become the topper in exam. Right, doctor? So that is very, very important. Sit with a couple of friends. One of you buy, download it, and then share it with your friends, no problem. But all of you sit and consume the content, which is very focused. Yeah. So thank you, Solitary One, for the wonderful work of sharing the videos to the friends. Good. Now, doctor, influenza, pandemics, influenza, epidemics. There is a difference between the two. Pandemics are because of the RNA segment reassortment and leading to antigenic shift, whereas epidemics are because of the mutation in hemagglutinin neuraminidase leading to antigenic drift. Drift से होता है epidemic, shift से होता है pandemic, is what you need to remember. So during an influenza pandemic, what do you get? You get RNA segment reassortment. And that lead to the antigenic shift. It involved major changes in the hemagglutinin and neuraminidase, and it required newer vaccines. Whereas influenza epidemics, there are the mutations in hemagglutinin, neuraminidase, antigenic drift. They're directly the mutations in HA and NA. They lead to seasonal epidemics. Only minor changes in HA and NA is what you need to remember. Just what it required to survive an epidemic. You need to have a regular annual vaccine and update your immune system. Now, rabies and CNS invasion. How will rabies virus can travel through the CNS? Very good. Once more, another student has just bought the PDF and downloaded it to become the proud owner of the 600 high yield items and about 5,000 high yield facts. Rabies virus binds to acetylcholine receptors and retrogradely axonal transport occur into the CNS. There's a reason rabies injuries are divided depending upon how close they are to the brain. Rabies lead to encephalitis. Post-exposure prophylaxis is very, very critical, is what you should remember. How does HIV infection bind to the helper T cells? It binds CD4 with the help of the co-receptors called CCR5, CXCR4. And CCR5 is early and CXCR4 is late co-receptor. It leads to immunodeficiency. Granulomas. Who is responsible? Macrophages present the antigens to CD4 and secrete interleukin 12 is very, very important, doctor. Interleukin 12 is responsible for the granuloma. Now, a patient has chronic cough, weight loss, has lung granulomas. Very good. One more student has just now purchased the Sprint 5 PDF, which has 5,000 high yield facts and almost 500 plus items for you to rapidly revise for the coming neetpg exam. Very good, doctor. Now, a patient with chronic cough, weight loss, has lung granulomas. So it is the CD4 plus T cell secreting interleukin 12. Where do you see granulomas, doctor? Caseating granulomas are seen in TB. Non-caseating granulomas are seen in sarcoidosis, is what you should remember. Why the cancer cells amar ho jate hain? Why उसके लिए मृत्यु नहीं होता है? That limitless replicative potential of the cancer cells is because the reactivation of telomerase. Telomerase, though the name says, ACE is not cutting the telomere. It is increasing the length of the telomere. Telomerase is a misnomer. Telomerase is not cutting. It is basically lengthening the telomere. So the reactivation maintains and lengthens the telomeres. It prevents the shortening of the chromosomes and aging seen in many cancer and target for many anti-cancer therapies. How can a cancer invade the tissues? Decreased E-cadherin function. E-cadherin function. It leads to intercellular junctions lost. The basement and extracellular matrix get degraded by the metalloproteinases. It increases the cell attachment to ECM proteins, and it facilitates the cell locomotion and vascular dissemination. Then comes persistent truncus arteriosus. It is the failure of the aortopulmonary septum formation. Between aorta and pulmonary artery, there is a septum. Aortopulmonary septum फॉर्मेशन अगर फेल हो गया तो आयोर्टा पल्मोनरी एक ही कमरे के अंदर रह जाते. An infant is diagnosed with persistent truncus arteriosus. And what is it because of, doctor? It is due to failure of the aorticopulmonary septum to form. That lead to single arterial trunk from the heart. Commonly, truncus arteriosus and DiGeorge syndrome are associated. And because of this, oxygenated, deoxygenated blood will mix with each other, and that lead to development of the cyanosis is what you need to remember. Transposition of the great arteries. That means aorta, instead of arising from the left ventricle, arises from the right ventricle, and the pulmonary artery, instead of arising from the right ventricle, arises from the left ventricle. How does that happen? It is the aortopulmonary septum failure to spiral. It's like a pole dancer in the Thailand Bangkok pub, right? So there is a spiraling required. If it doesn't spiral, transposition of great arteries will occur. So a newborn with cyanosis typically, what are the 4 cyanotic heart diseases, doctor? Fatapat follow. T for truncus arteriosus, T for transposition of great arteries, T for pathology of Fallow, T for tricuspid atresia. So you should be very sure on all these things, doctor. Now, whenever transposition occurs, it leads to a parallel systemic pulmonary circulations. It requires immediate surgical intervention. Often, transposition typically is associated with ductus arteriosus and a patent foramen ovale. And it leads to severe cyanosis at birth, is what you need to remember. Where do you get TET spells? Where will squatting relieves the cyanosis? Typically in pathology of Fallow. So basically, in pathology of Fallow, there is a overriding aorta. That means aorta opens to its mouth into both the right ventricle and also into left ventricle. So the right ventricle blood, instead of going into pulmonary artery, right ventricle mein kya rehta? Bad blood. Bad blood, instead of going into pulmonary artery, will go into this overriding aorta. So why it is not able to go into pulmonary artery? Because there is a associated pulmonic stenosis. Because the pulmonic stenosis, the right ventricle blood unable to go into pulmonary artery will go into this overriding aorta. So anything that increases the right ventricular outflow into pulmonary artery, the obstruction, anything that increases will increase the cyanosis. That is what you need to remember. So any crying, fever, exercise, they all increase lead to pulmonary spasm. pulmonary artery spasm, leading to increased right ventricular outflow obstruction, and that makes more right ventricular blood go into overriding aorta, leading to right to left shunt, and that lead to cyanosis. If you do squatting, you are increasing the pressure in the aorta. Then the blood, instead of going into overriding aorta, because squatting caused aortic pressure to increase now. So instead of going into aorta, it will then go into pulmonary artery, and right to left shunt decreases. That relieves the cyanosis, and it requires surgical correction, is what you need to basically remember. So now, doctor, Eisenmenger syndrome. For a normally ASD, VSD, PDA, these three are called left to right shunt. Left to right shunt does not lead to cyanosis, only right to left will cause. Or a period of time, once there is a right to left shunt, left to right shunt, the right side circulation regularly receives the venous return and also the left sided blood. Together become too much blood on the right side, and that lead to lot of blood from right ventricle into pulmonary artery, and pulmonary artery develops pulmonary hypertension. The moment pulmonary hypertension develops, instead of right ventricular blood going into the pulmonary artery, it will reverse and go into the left side of the heart. So the left to right shunt become then right to left shunt, which is called Eisenmenger syndrome. So when will this happen? A long-standing ASD, VSD or PDA, which is a cyanotic heart disease, for a long period of time, if it is there, that lead to more blood on the right side, leading to right ventricular hypertrophy, pulmonary hypertension, and causes right to left shunt, reversal of the shunt. Instead of left to right, it becomes right to left. So there's a late cyanosis, clumping, polycythemia, they all develop in Eisenmenger. Now, doctor, atherosclerosis is due to endothelial cell dysfunction. Foam cells, fatty streaks, LDL accumulation, macrophage activation, smooth muscle cell migration and proliferation, extracellular matrix deposition, leading to complex atheromas. So every day of our life, there's so much free radical injury and leading to endothelial cell dysfunction, finally responsible for our strokes, for our heart attacks, etc. Now, thoracic aortic aneurysm, why will it occur? Because of cystic medial degeneration is responsible. So a patient with Marfan syndrome is at risk of cystic medial degeneration leading to thoracic aortic aneurysm. And it requires surgical repair if large or if it is symptomatic. In myocardial infarction, the coronary artery atherosclerotic plaque can rupture and can lead to an acute thrombus formation. So, how will examiner ask this question? Chest pain, ST elevation with MI, what is the most likely cause? You should know rupture of the atherosclerotic plaque. That lead to ST segment elevation is what you should remember. So what is Barrett's esophagus? Any chronic gastroesophageal reflux disease lead to metaplasia, not dysplasia, metaplasia. Barrett is a metaplastic. Later it became dysplastic, then it will become adenocarcinoma of the esophagus. Acute gastritis is because of the NSAIDs that decrease the prostaglandin E2. Normally, prostaglandin E2 maintains the blood flow to the stomach mucosa and maintain the mucosa, and that lead to decreased gastric mucosa. NSAIDs will go and inhibit cyclooxygenase, reduce the prostaglandins. Alcohol, smoking, they all increase the risk of acute gastritis. So we give proton pump inhibitors and H2 blockers. So what is celiac disease? Autoimmune intolerance to gluten is what you need to remember. How will be the presentation, doctor? Chronic diarrhea, weight loss, biopsy show villus atrophy. Think about the celiac disease. Which part of the gut? Proximal jejunum, distal duodenum, most commonly associated. Which skin disease with celiac disease? Dermatitis herpetiformis. Which antibodies in celiac disease? IgA, anti-transglutaminase antibodies, anti-TTG antibodies of IgA type. And how do you treat? Gluten-free diet. In Crohn's, unlike ulcerative colitis, it is a transmural inflammation. All the layers of the gut are involved. That's the reason fistula formation is the nature of Crohn's disease. Cobblestone mucosa, skip lesions, non-caseating granulomas, and it involves all the way from mouth to anus is what you need to know. And there's an increased risk of adenocarcinoma in Crohn's. What is Meckel's diverticulum, doctor? Persistence of the vitelline duct is Meckel's diverticulum. How will be the clinical Binet-based question in the tomorrow's neetpg? You should know. Painless rectal bleeding, technetium 99M scan show ectopic gastric tissue. That is how you make a diagnosis of Meckel's diverticulum. So what is the rule of 2? 2% population, 2 feet from ileocecal valve. And there is ectopic gastric or pancreatic tissue. It can lead to obstruction, it can lead to bleeding, and you do Meckel's scan. It is a painless rectal bleeding in Meckel's diverticulum. In Hirschsprung's, there's a loss of function mutation. In RET gene, RET gene, a newborn fails to pass the meconium within 48 hours, there is a distended abdomen. That is how the Hirschsprung's present. Hirschsprung's is because of the problem in the failure of the neural crescents. There are no ganglion cells in the distal colon. It is the full thickness rectal biopsy which will give you diagnosis, and treatment is surgical resection of that aganglionic segment of the bowel. Adenoma, carcinoma sequence in colorectal cancer. It is due to the loss of APC gene leading to KRAS mutation. APC, KRAS leads to colorectal cancer. Once more, remember, doctor, every neetpg और 100 साल तक भी without a question on colorectal cancer, मुझे एक neetpg पेपर दिखाओ, मैं अभी इस्तीफा देता हूं. ठीक है? Now, familial endometrious polyposis guy, how will he go into colorectal cancer? The moment APC mutation is there, TP53 is affected. Normally TP53, DCC, these two are the tumor suppressor genes. Unregulated intracellular signaling will lead to the development of adenoma to carcinoma sequence. So there's an increased risk of colorectal cancer with the diet, smoking. After 50, regular colonoscopy need to be done for the surveillance. Why there is a cirrhosis of liver? It is the stellate cells that lead to fibrosis in cirrhosis. Cirrhosis lead to portal hypertension, risk of hepatocellular carcinoma, and you need to treat with liver transplant. Aspirin, don't give it in pediatric population when they have fever, when they have a viral fever. It can lead to Reis syndrome. So how will be the typical clinical Binet-based MCQ in tomorrow's neetpg, FMG, INICET, doctor? Vomiting, confusion, liver dysfunction, acute fulminant failure after taking aspirin for a viral illness. You have to jump and answer Reis syndrome. Reis syndrome, why there is acute fulminant failure? Because the aspirin goes and inhibits the mitochondrial enzymes. It leads to microvesicular fatty change, not macro, microvesicular fatty change. It leads to hyperammonemia, rise of transaminases. Avoid aspirin in the children is a very, very important rule, doctor. Hepatic encephalopathy typically occurs whenever there is a cirrhosis with portosystemic shunt. So how will examiner will ask this? Cirrhosis patient has confusion, asterixis, lab show elevated ammonia. What is your diagnosis? Hepatic encephalopathy. Treat with lactulose, rifamycin, which is a local antibiotic. It comes like a brand called Rifagat, 400 milligrams. We give twice daily. Flapping tremor, asterixis. Then alpha-1 antitrypsin deficiency. It is a misfolded protein in the liver which is responsible. So young adult shortness of breath and also liver cirrhosis. Both lung failed, liver failed. Think about alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin inhibits elastase in lung. What type of emphysema is alpha-1 antitrypsin? Pan-acinar emphysema. In exam hall, these are all such a frequently asked questions. You should not do it wrong. Fast positive globules in hepatocytes. Treat with enzyme replacement. Then Wilson's disease. Any mutation in ATP7B gene leading to copper accumulation lead to Wilson. There will be neurological symptoms, Kaiser-Fischler rings, low ceruloplasmin. That is how you diagnose. Treat with penicillamine, and liver transplant if it is a very severe case. Hemochromatosis, HFE mutation that lead to iron overload. A middle-aged patient with diabetes, skin hyperpigmentation, arthropathy, elevated ferritin, elevated transferrin saturation. What is your answer? Hemochromatosis. It is also called bronze diabetes, the pancreatic dysfunction. So do phlebotomy, do chelation. It can lead to cirrhosis. It can lead to cardiomyopathy. So a untreated case of hemochromatosis, what is the cause of death? It is a cardiomyopathy leading to the development of cardiac failure leads to death. But a treated case of hemochromatosis for a long period of time, iron goes and damages the liver, leading to cirrhosis, leading to hepatocellular carcinoma, the death in a chronic case of hemochromatosis is what you need to remember. Then comes gallstone ileus. The gallstone in the gallbladder will form a fistula between gallbladder and GI tract and goes into the GI tract and goes to the ileum and lead to obstruction of the ileum. So any elderly patient with intermittent abdominal pain, vomiting and imaging is showing a gallstone. Classical case. And how do you know that there is a tract formed between gallbladder and GI tract? The air in the GI tract will go through enter into gallbladder and go into biliary tree. Air in biliary tree on imaging in an abdominal pain patient. Think about gallstone ileus. It requires surgical removal of the stone. It can lead to bowel obstruction. Acute cholangitis. Cholangitis is different from cholecystitis. Cholecystitis is inflammation of the gallbladder. Cholangitis is the inflammation of the bile duct. It leads to biliary tree obstruction, leading to infection, leads to acute cholangitis. So what is the classical clinical vignette, doctor? You should remember Charcot's triad: fever, jaundice, right upper quadrant pain. Fever, jaundice, right upper quadrant pain. Elevated bilirubin, elevated alkaline phosphatase. Oh my God. You need to jump and answer that it is cholangitis. Treat with antibiotics. Do ERCP. It can lead to sepsis. You need to be very, very diligent and emergent in treating it. Acute pancreatitis may. Why pancreas get damaged? Any gallstone or alcoholism are the two most common causes for pancreatitis. Our own pancreatic enzyme will go and digest our own pancreas. What complication of acute pancreatitis? Pseudocyst, necrosis, nil per orally. Give only IV fluids, and it leads to systemic inflammation. It can lead to ARDS, which can lead to death. And there is a grading done for the degree of acute pancreatitis using the CT scan. Is it 1/3, or 2/3, or more than 2/3? You find necrosis on CT is the way to grade the severity of the pancreatitis. RH hemolytic disease of the newborn. It is because the anti-D, IgG antibodies, as all of you know very well. So it leads to hydrops fetalis. You need to treat with exchange transfusion. You should also know what are the indications of the exchange transfusion. Why there is an anemia in lead poisoning? because lead goes and inhibits ferrochelatase, LR dehydratase, the two enzymes inhibited by the lead. Favorite question of the examiner. Child with anemia, abdominal pain, basophilic stippling on the blood smear. Now only go to the Google and look for how the basophilic stippling typically looks like. Thank you, Vinod. I paid and downloaded the PDF, sir. Thank you so much for doing that. And please read it. That's very important. Right? That's called Balthazar score. Very good, Dr. Prema. Wonderful. So, thank you so much for downloading after paying on learnograph.com. So, let me tell you, doctor, if you pay 30,000, 40,000, buy a video library on an app and you are procrastinating, my kal sununga, parson sunenge, baad mein sunenge, only for our mental satisfaction, we buy all these costly programs. So how do you get seat? You get seat only if you have 2-3 friends with whom you consume the material. First of all, that material should not be too exhaustive. It should be the one which you can repeat, you can revise. That's the whole purpose of these sprint sessions and this PDF stuff, right? So now, continuing our journey, anemia of chronic disease. What's the main reason in anemia of chronic disease? Like tuberculosis, like rheumatoid arthritis, like SLE, there's an inflammation. Inflammation increases the hepcidin, which is responsible. This hepcidin will inhibit the absorption of the iron. So there is a normocytic normochromic anemia. There's a decreased iron release from the macrophages in case of anemia of chronic disease. So the main difference is what? Iron deficiency anemia may, ferritin levels will be low, whereas anemia of chronic inflammation where ferritin levels will be typically high is what you need to basically remember. So Vinod says, I'm your old FMGE student and I cleared my FMGE in 2019 because of you, sir. Oh, that is a great compliment, Dr. Vinod. I will always remember it. Any teacher always yearns secretly for a compliment. Remember that. We think that why to compliment the teacher? बहुत लोग compliment करते बोल के. No. Lot of people don't compliment. Few people definitely like Vinod will come back and say, sir, I got seat because I attended. I could get a little bit of inspiration by attending you. So good, doctor. Keep it up. The same spirit. Let me tell you, so many people, almost 300,000 doctors, sometime in an airport or in a movie theater or in a shopping place or in some hospital, somebody will come and say, hey, sir, that day I used to take your classes. Thank you so much. I got, now I'm a top. What are you doing? I asked. They say, I'm a top neurologist. I'm a top urologist. Wow. I feel so proud. That is the real incentive of being alive as a teacher. So on June 6th, I have hit my 51st year. I finished, entered 52. I had been teaching right from the age of 17 when I was in medical college, right? I used to conduct revision sessions to my 2-3 year seniors also in the medical college days, way back in 1991, 92, right? Some of you are not born at that time. But what keeps a teacher is alive is when he is able to inspire the students to consume a revision content and get more confident to face the exam and one day become toppers, their dream seat, and make a wonderful living, right? And of a great use for the world. So, doctor, um, yes. Sure, Dr. Prema. Hope I clear this exam. Will definitely come back and message here. Definitely, doctor. Most welcome. And I'm very confident and very sure, right? If you know Balthazar grading, you are sure to clear the exam, doctor. Please remember that. Hmm? So, G6PD deficiency. Any decreased G6PD, glucose 6 phosphate dehydrogenase, decreases NADPH because that affects the pentose phosphate pathway. And any oxidant stress lead to hemolysis because no NADPH means you can't have reducing equivalents to detoxify the free radicals. This XPD is X-linked recessive. Favorite question. And fava beans are one of the triggers. Sickle cell anemia is a point mutation, whereas thalassemias are deletions. Of course, beta thalassemia are once more point mutations, but alpha thalassemias are deletions, chromosomal deletions. Sickle cell anemia also point mutation in the beta globin gene is what you need to remember. Anemia, episodes of pain, positive sickle cell test, classical. What is happening due to mutation? Glutamic acid is substituted by the valine is what you should remember. It can lead to vaso-occlusive crisis. Hydroxyurea. What will hydroxyurea will cause? It will cause more amount of hemoglobin F, fetal hemoglobin formation. Fetal hemoglobin will not sickle because it does not have a beta chain, right? So that's the point. Funda behind giving hydroxyurea is to increase the fetal hemoglobin so that sickling is decreased. You give transfusions. Long period of time, sickle cell anemia lead to autosplenectomy. Autosplenectomy will decrease the complements required for opsonization, and a decreased opsonization lead to infection with encapsulated organisms is what you need to remember. So, doctor, tomorrow, once more, before I go to hospital in the morning, I'll try to connect back with you all guys, wonderful guys, and I'll try to take an hour or 1.5 hours of session. Oh my God, we finished almost 1 hour 45 minutes feature film length. Thanks for staying online. Almost I can see 25 students online, right? And you are the ones who give energy to the teacher to study along with you in this last moment of exam. So tomorrow morning before I go to hospital, I'll try to take 1.5 hour session. And once more tomorrow night, we will meet up. So let us study together. Another 11 to 12 days, don't get disheartened. You know, age and exam leftover time are just a number. What you need is a quick cursorial revision. लास्ट मोमेंट में जितना पढ़ सकते उतना पढ़ के जाएंगे एग्जाम को ऊपर वालों को हाथ में है जहां पता ठीक है सो गुड नाइट enjoy be happy have a sweet dream and think oh that within another 1 to 2 months I'm going to run from one ward to the other ward carrying the blood for giving a blood transfusion. I'll be doing a CPR. I'll be doing a cardiac resuscitation. I'll be putting an intercostal drainage tube. I'll be presenting in a radiology session. I'll be scrubbing my hands to join the theater. I'll be delivering a baby. That is what we need to dream. And we all were losers before we became toppers. We all passed through the same fears, not just now. About 25 years ago also, the same agony was there. Right, doctor? So enjoy, and once more, let's catch up. Don't forget to give your compliments in the comment box below the video. That will help to make this video viral, and don't forget to give a thumbs up, like to this video. Good night and enjoy the game.